Starting insulin made ridiculously simple. I'll have you know the last patient I saw right before I came here, I actually used the talk in my head to start insulin. So I have no disclosures. So a brief history of insulin. So the connection between diabetes and the pancreas was first made late in the 19th century, following which the search for the active principle from the islets of Langerhans began in earnest. At this time, diabetes was a death sentence. Treatment was starvation. On October 30th, 1920, a young doctor in Toronto, Canada, named Frederick Banting, was reading an article by a pathologist who had conducted post-mortem exams of pancreata in which the duct had been blocked by stones. The pathologist noted total loss of exocrine tissue, but preservation of endocrine tissue. Banting later wrote in his memoirs, "It was one of those nights. I thought about the article and I thought about my miseries and how I would like to get out of debt and away from worry." Clearly, this is something that has not changed in medicine. The idea occurred to me that by the experimental ligation of the pancreatic duct and the subsequent degeneration of a portion of the pancreas, that one might obtain the internal secretion free from the external secretion. I got up and wrote down the idea and spent most of the night thinking about it. The rest is history. By May 1921, he had convinced John McLeod to use his lab to set up animal experiments. Along with his medical student, Charles Best, they presented their work to the American Physiology Society in December 1921. There was the first human success with injectable insulin in January 1922, and by May 1922, they had an agreement for commercial production. Banting and McLeod were awarded the Nobel Prize in October 1923. From concept to translation was 15 months, and to commercialization, 19 months. Clearly not something that would be done this day and age. Insulin immediately began to save the lives of patients with type 1 diabetes. However, due to the progressive nature of type 2 diabetes, many of those patients will eventually require insulin to maintain goal hemoglobin A1C due to the degradation of pancreatic beta cells over time. However, many who could benefit do not receive insulin in a timely manner. Part of this gap appears to be due to reluctance to take insulin among patients and resistance to prescribing insulin among healthcare providers. A group led by Carter et al. Looked at the reasons for the above after a study they published in 2009 observed that 4.5% of insulin-naive patients who were prescribed insulin never filled the prescription, and an additional 25.5% had zero refills. Carter et al. In 2010 found that patient reluctance may be due to the following, and I'm sure all of this is familiar to us. Injection phobia. I don't know how many times I see patients like cringe when you're like about to test insulin. Misconceptions about insulin risk. 35% in one study believed that insulin causes blindness, renal failure, amputation, heart attacks, strokes, and early death. That there were hypoglycemia concerns, that it would have a negative impact on social life and job. Believe it or not, there's still a lot of patients, they think like the vials, you need to carry it in a special container, you need ice. They don't know about the pens. That there's a sense of personal failure, that they did something wrong if they need to start insulin. And that there's also physician reluctance, which may be due to the following: an uncertainty in medicine regarding diabetes and its treatment, the nature and consequence of insulin therapy, and just complex dosing. So part of my job today is to remove some of these barriers and to turn the complex into the ridiculously simple. So questions that will be answered: who's a candidate for insulin treatment? How do I start insulin, and which insulin do I use? What do I do with the other diabetic medications once insulin is started? And the blood glucose is uncontrolled on basal insulin. How do I start bolus insulin? So who is a candidate? So this is just a brief case. So 40-year-old man presents for follow-up of his type 2 diabetes. He was last seen a year ago. At that time, he's on metformin 1,000 twice a day with a hemoglobin A1C of 7.2. He now complains of polyuria, polydipsia, and blurry vision. He reports compliance with his metformin. The A1C is now 10.2, so do you add a second oral agent or do you start him on insulin? So this is a recent update of the diabetes algorithm that was initially published in 2009 by the American Association of Clinical Endocrinologists, otherwise known as ACE. And the goal was to assist physicians in the management of type 2 diabetes. Is this a pointer? Okay, I'm not sure where the pointer is, but so on the top you can see, so the pathways are stratified by A1Cs, whether or not somebody's already on medication or whether or not they're drug naive. And so that red square in the second path under dual therapy, so that's the first part where insulin comes in. If patients have not had a reduction in their A1C after 3 months on monotherapy, then it's reasonable to start insulin, but there is an exclamation point to use with caution due to risk of hypoglycemia. And then same thing with triple therapy, the option to start insulin. If the A1C is more than 9% when you first see them, then you can start insulin immediately with or without other agents. Around the same time that ACE came out with their algorithm, so did the American Diabetes Association, and so this is their most recent update, which also shows that after 3 months of lifestyle modification and metformin, if patients are not controlled, then you can consider starting insulin. And on the left side, those dotted lines denote that you can do a rapid progression from either a monotherapy or dual regimen in patients that have severe hyperglycemia, which they were considering an A1C of more than 10%. So the ACE for candidates for insulin therapy, so according to ACE, you can consider adding to a first-line agent if the A1C is greater than or equal to 7.5%, if the A1C is not at goal on triple therapy after 2 to 3 months, if the A1C is more than 9% under treatment of any kind, and if they're drug naive with an entry A1C of more than 9 and symptoms of hyperglycemia such as polyuria, polydipsia, and polyphagia. According to the ADA, if your A1C is above 7, if there's lifestyle changes and metformin fails after 2 to 3 months, you can add insulin, and to highly consider insulin if the entry A1C is greater than or equal to 9%, and any A1C with symptoms of hyperglycemia. So according to that patient, he had an A1C of, I think it was 10 or 10.2. He had been on metformin for a year, compliant with his medication. He now had symptoms of hyperglycemia. You would want to start him on insulin. Actually, right before I came here, the patient that I had started on insulin, he had a creatinine of 1.65. He was not on metformin. He was on max doses of glipizide and Januvia appropriate for his GFR, and his A1C was now 7.6%, and his fastings were above goal, and so I started him on basal insulin. How much insulin? Well, we'll talk about that in a second. So how do you start insulin, and which insulin do you use? So you have rapid-acting insulins. You have insulin Lispro, Aspart, and glulisine. You have short-acting, the regular insulin. The long-actings, Glargine and Detamir. You have intermediate-acting, NPH. And then you have biphasics or pre-mixed insulin analogs. I'm going to focus on the long-acting and the rapid-acting. So the long-acting, you have Glargine and Detamir. Time to onset and peaks are slightly different, but approximately the duration of action is 18 to 24 hours. And with the rapid acting, you have onset in about 5 to 15 minutes. They peak in about 30 to 90 minutes, and they last about 3 to 5 hours. So which insulin do you start? So the two societies differ slightly in their recommendations. So according to ACE, you can start with a basal insulin using a long-acting insulin, generally given once daily, or a pre-mixed insulin using a rapid-acting analog and protamine, basal bolus insulin or multiple daily injections using rapid-acting plus long-acting insulin, or a prandial insulin regimen using a rapid-acting without long-acting analogs. And this is possible if the patient's currently on an insulin sensitizer such as metformin. The ADA says that you can start with bedtime or intermediate-acting insulin, a bedtime or morning long-acting insulin. So just of note, the ACE Society recommends against the use of regular insulin or NPH because these preparations do not have a sufficiently predictable time course that adequately mimics the normal physiologic profile. So rather than starting with multiple daily injections of different types of insulin, often it's more manageable for both the patients and providers to just begin with a once daily basal insulin instead of a rapid-acting insulin to be taken before meals. The Treating to Target and Type 2 Diabetes Study Group compared the effects of adding basal insulin versus prandial coverage in patients with type 2 diabetes on oral agents. It was a 3-year, multi-center, open-label, randomized controlled clinical trial. And this study reports the results of the first year, which compared the efficacy and safety of adding biphasic, prandial, or basal insulin to the treatment of patients with type 2 diabetes who had suboptimal glycemic control while receiving maximally I can hear that. There's someone on the phone. While receiving maximally tolerated doses of metformin and sulfonylurea. I feel like we should have had a thing like in the movies about turning on the phone. So patients were on biphasic insulin aspart twice daily, prandial insulin aspart 3 times daily, and basal insulin detamere once daily, twice if required. So outcome measures at 1 year were the mean glycated hemoglobin level, the proportion of patients with a glycated hemoglobin of 6.5% or less, the rate of hypoglycemia, and weight gain. So all insulin regimens were associated with clinically relevant and sustainable reductions in A1C levels. Target levels were achieved in a minority, 16% with an A1C of less than 6.5%, and 39% with an A1C of 7% or less. Biphasic and prandial regimens lowered A1C to the same extent and to a greater degree than the basal regimen, but there were no differences seen among the groups for patients with a baseline A1C of 8.5% or less. There was more hypoglycemia with the prandial and the biphasic insulin, and there was less weight gain with the basal insulin group. So introducing insulin with a one-shot daily of long-acting insulin to provide basal coverage may be an easier transition to make. I know a lot of the patients, one of the primary concerns is hypoglycemia, and as you saw from that previous study, there's less hypoglycemia, and it's also an accepted approach according to both ACE and ADA. So this was a Cochrane review looking at insulin detamere versus insulin glargine for type 2 diabetes. It was 4 trials lasting 24 to 52 weeks. Over 2,000 people were randomized to either insulin glargine or insulin detamere. Insulin glargine was dosed once daily in the evening. Insulin detamere was initiated once daily in the evening with the option of an additional dose in the morning in 3 studies and initiated twice daily in 1 study. 13.6 to 57% were injecting twice daily at the end of the trial. There was no significant difference between treatment groups in the following categories: glycemic control with or without hypoglycemia, nocturnal and severe hypoglycemia, variability of fasting plasma glucose or glucose values in 24-hour profiles. Insulin detamere was associated with less weight gain. Treatment with insulin glargine resulted in a lower daily basal insulin dose and a lower number of injection site reactions. The author's conclusions that there was no clinically relevant differences in efficacy or safety between glargine and detamere in targeting hyperglycemia. However, to achieve the same glycemic control, insulin detamere was often injected twice daily in a higher dose but with less weight gain, while insulin glargine was injected once daily with fewer injection site reactions. So starting basal insulin, so there's 2 approaches. You can start with a fixed dose of 10 units per day, which happens to be what I started in my patient this afternoon before coming over. Or you can use a weight-based dose of 0.2 units per kilogram of body weight in patients who have normal kidney and liver function. So a 165-pound man who weighs 75 kilograms would be starting with 15 units. Patients should monitor and record fasting blood glucose every morning and more frequently to watch for hypoglycemia and to document excursions related to meals. The dose of basal insulin can be increased every 2 to 3 days if the fasting blood glucose is not in range. If hypoglycemia occurs or fasting glucose is less than 70, you can reduce the bedtime dose by 4 units or 10%, whichever is greater. So again, when the ACE came out with the updated version of the diabetes algorithm recently, they also produced this for starting insulin. So on the left, starting basal insulin. So here you can, depending on the A1C, start with 0.1 to 0.2 units per kilogram if you're afraid of hypoglycemia, or if the A1C is more than 8, 0.2 to 0.3 units per kilogram. I also happen to use a lower dose because this patient's A1C today was 7.6%. You can also, it talks about titrating the insulin every 2 to 3 days to reach your goal. And there's two different options. You can just, every few days they can go up by 2 units if their sugar, their fasting sugar is not at goal. Or more specifically, it talks about if the fasting glucose is consistently above 180, you can add 4 units. Or if it's 140 to 180, you can add 2 units. Or if it's 110 to 140, you can add 1. I'd probably advise sticking with the 140 range. If it's less than 140, you probably don't want them to be titrating themselves at home due to risk of hypoglycemia. So common pitfalls with basal insulin dosing. So increasing the basal too much before adding prandial insulin. In this situation, the basal insulin is treating postprandial hyperglycemia, and it predisposes to fasting hypoglycemia. I can't stress this enough. This is probably the #1 problem that patients come to me with when they've been started on insulin, someone other than an endocrinologist. Patients just the Lantus just goes up and up and up, and before you know it, they're on 50 or 70 units, once a day, and they're waking up in the middle of the night with lows, so they're eating before bedtime, just like Dr. Lamb was talking about, to get over the lows. So if you stick to that rule of not increasing it by more than 0.5 units per kg, then you can help to decrease this risk. So don't advance to more than 0.5 units per kg per body weight for basal insulin without first adding a rapid-acting insulin with meals. And for patients, actually, when I'm starting basal insulin, I usually give them a handout, and I tell them the limit, because once you start to let them increase on their own, if their sugars are high, I give them a number that says, do not go above this, and if your numbers are still high, then call me, and we'll talk about the next step. So what do you do with the other diabetic medications once insulin is started? So metformin should be continued. It suppresses hepatic glucose production. If on basal insulin, you may continue the secretagogue therapy, but just be mindful of the increased risk of hypoglycemia. Concomitant use of TZDs and insulin has been associated with weight gain, fluid retention, increased risk of congestive heart failure, and increased risk of fracture risk in men and women. And you want to stop the secretagogue if on multi-dose insulin. That's another common thing. Patients come in on glimepiride and glipizide, and they're also taking Humalog or Novolog before their meals. So just stop the secretagogue. And glucagon-like peptide-1 receptor agonists. So liraglutide is approved for use with insulin glargine and insulin levemir. Exenatide is approved for use with insulin glargine. And a review by Burley et al. Looking at GLP-1 receptor agonists on add-on therapy to basal insulin in patients with type 2 diabetes found that there was additional lowering of the hemoglobin A1C without a major risk of hypoglycemia, that there was lower basal insulin requirements, and that you had decreased postprandial plasma glucose levels, and there was weight loss, or at the very least, less weight gain. So the blood glucose is uncontrolled on basal insulin. How do you start bolus insulin? So as mentioned before, the rapid-acting insulins have an onset of about 5 to 15 minutes, peak at 30 to 90 minutes, and last for about 3 to 5 hours. So they should therefore not be given more than 15 minutes before a meal. Patients must understand the importance of frequent blood glucose monitoring once prandial insulin is added. You want to monitor no less than 4 times per day before meals and at bedtime. You can begin with about 4 to 5 units. You want to add a rapid-acting insulin at breakfast if the blood glucose before lunch is above goal. You want to add a rapid-acting insulin at lunch if the blood glucose before dinner is above goal. And you want to add a rapid-acting insulin at dinner if the blood glucose before bed is above goal. And helping to break it up, sometimes patients get completely overwhelmed when suddenly you're starting before each meal. And sometimes a good rule of thumb is just whatever their biggest meal is, maybe start insulin first with that meal and then work your way up as you need to. It's much less overwhelming to the patient, and they're more likely to be compliant with treatment. You can adjust by 2 units every 3 days until the blood glucose is in range. And if the A1C continues to be out of range, you want to then have them check 2 hours after a meal and then adjust the preprandial rapid-acting insulin that way. So again, back to this algorithm. So ACE has more specifics about adding the prandial insulin, talking about if you're going to be using both basal and bolus insulin, total daily dose of about 0.5 units per kg, about 50% the basal insulin and 50% of the prandial insulin. And again, here it talks about increasing or adjusting the regimen every 2 to 3 days. You can, again, like mentioned before, with the basal, do a fixed regimen of increasing it by 2 units, or you can be more specific depending on if the blood glucose is above 180 or above 140. So some things to keep in mind. It's important to achieve good glycemic control in the long term to avoid complications of diabetes. However, this does not have to be done in hours or days. Rapid improvement in glycemic control may be associated with bleeding from proliferative retinopathy, patient dissatisfaction, or even dangers related to hypoglycemia. So start low and go slow. Okay.